Hey everyone, welcome to This Explainer. I'm so pumped you're here today because we're going to radically change the way you look at that piece of equipment currently hanging around your neck. Seriously, I want you to stop thinking of your stethoscope as just some basic listening tube. Instead, we really need to start framing it as what it actually is, a finely tuned acoustic instrument. I mean, think of it like a musician holding a Stradivarius, right? Your diagnostic power literally depends entirely on how well you master it.
So here's a serious question to kick things off. Are you missing the heart's hidden warnings? Honestly, if you're placing your stethoscope on a patient's chest and only listening for that standard lub-dub, the basic S1 and S2, you are missing half the plot of your patient's cardiac story. That lub-dub, it's just the baseline. The real diagnostic gold, those subtle warnings of severe pathology, they usually lie hidden right there in the spaces between those sounds.
And capturing that gold? Well, that requires technique. This core difference right here underpins our entire explainer. Because look, your acoustic instrument is completely useless if you don't know how to physically wield the thing. On one side, we've got the diaphragm. That's built for high-frequency sounds, and it requires firm pressure against the chest wall. But flip it over to the bell, which is designed to capture those low-frequency rumbles, and that absolutely must be applied with very light pressure. That physical distinction is the master key to unlocking everything we're about to cover.
Okay, let's dive into this. Here is our roadmap. Number 1, beyond the lub-dub. 2, systolic clicks, the diaphragm. 3, decoding the diastolic sequence. 4, gallops, mastering the bell. And finally, 5, the auscultation cheat sheet.
All right, section 1, beyond the lub-dub. So, what are we actually hunting for when we place that stethoscope on a chest and lean in to listen? Basically, we're hunting for added heart sounds. These are brief, discrete auditory vibrations that occur entirely outside of your standard S1 and S2, and they aren't just random background noise, okay? They reveal critical cardiovascular pathology. Crucially, these sounds are categorized with absolute precision by two things. First, their exact timing in the cardiac cycle, so whether they're systolic or diastolic, and second, their frequency. And remember, as we literally just talked about, that frequency dictates exactly which side of the stethoscope you need to be using.
Moving to section 2, systolic clicks and the diaphragm.
Let's transition our focus specifically into systole, the phase where the heart is actively pumping. During systole, the added sounds you're going to encounter are primarily clicks. Now these are high-frequency vibrations, which means I need you to press your diaphragm firmly onto the chest wall to catch them. We basically divide these into two camps. First up, ejection clicks. These are produced by the opening of the semilunar valves. You'll hear these valvular ejection clicks in conditions like aortic or pulmonary stenosis. When a mobile but stenosed valve domes and just comes to this abrupt halt. You can also hear vascular ejection clicks from the sudden distension of great vessels, like in an aneurysm. Clinically, these are super easily confused with a loud S1, but the trick is that they generally do not vary with respiration. Well, actually scratch that, except for pulmonary ejection clicks, which are best heard on expiration. Then we have our non-ejection clicks. These are famously associated with mitral valve prolapse, or MVP. The timing of an MVP click is totally dynamic. So if you have your patient stand up or perform a Valsalva maneuver, you're decreasing their preload. That causes the ventricular cavity to shrink, leading to an earlier prolapse, which physically moves that click closer to S1. Honestly, it's a brilliant physical exam maneuver to keep in your back pocket.
Section 3, decoding the diastolic sequence.
As we push the timeline forward into diastole, the heart's relaxation phase, I gotta warn you, we are entering a much more complex sequence of sounds. When we look at diastolic added sounds, they follow this really exact chronological sequence based on their timing immediately after S2. Progressing through the timeline, we go from the opening snap to the pericardial knock to the tumor plop, followed by the S3, and then finally the S4. So let's set the stage and explore the distinct characteristics of each one of these players.
First up is the opening snap, or OS. This is a high-pitched sound, so again, we're in diaphragm territory here, representing the opening of the atrioventricular valves right during the isovolumetric relaxation phase. It's the absolute hallmark of organic mitral stenosis with mobile leaflets. The crucial thing to watch here is the timing. You really want to pay attention to that S2 to OS interval. If you hear a shorter interval, specifically we're talking that 40 to 60 millisecond range, that is a massive clinical clue. I mean, it's a classic board exam question for a reason. It indicates higher left atrial pressure and much more severe stenosis. Basically, the closer that snap is to S2, the worse the stenosis, period. Moving slightly later into early diastole, we have this absolutely fascinating acoustic contrast. On one hand, we've got the pericardial knock. This is a high-pitched sound seen in chronic constrictive pericarditis. I want you to imagine a structurally rigid, literally rock-like pericardium that just abruptly restricts diastolic filling. That sudden, harsh halt is what creates the knock. And unlike some other sounds we'll talk about, this knock actually gets louder during inspiration. Now contrast that acoustic profile with the beautifully named tumor plop. This is a totally different beast. It's a low-pitched sound directly associated with an atrial myxoma physically flopping into the valve orifice. And yeah, in case you were wondering, tumor plop is the actual official medical terminology. We doctors are nothing if not literal, right?
All right, moving on to Section 4, Gallops, Mastering the Bell.
Okay, so we are now moving away from the high-frequency snaps and knocks and into low-frequency rumbles. This is exactly where your physical technique matters the most. Right now, I need you to mentally flip your stethoscope over to the bell side and apply only very, very light pressure to the skin. First up here is the third heart sound, or S3, which is widely known as the ventricular gallop. This happens during the rapid filling phase of diastole. It's that low-pitched sound caused by blood just rushing into an already overfilled or non-compliant ventricle. Now remember, context is everything here. An S3 can be entirely physiological in, say, young, healthy athletes. But a pathological S3? That occurs slightly earlier in the cycle and is a massive, blazing red flag for heart failure.
Because it's such a low-frequency sound, it's incredibly difficult to catch if you aren't using the right maneuvers. So consider this your direct command for the wards. To actually hear an S3, you must apply the bell lightly at the apex of the heart. You have to roll the patient into the left lateral position. That brings the apex closer to the chest wall. And if you really want to augment this sort of thud-like sound, perform a passive leg raise. That increases venous return and completely amplifies that rapid filling.
Finally, we have the fourth heart sound, or S4. This one is known as the atrial gallop. It happens late in diastole, specifically during atrial systole, that active filling phase. It's the result of the atria contracting forcefully against a stiff, hypertrophic, or just non-compliant ventricle. Now, it is absolutely crucial to understand the physiology at play here. To hear an S4, the patient absolutely must be in sinus rhythm. Why? Well, because you need a healthy, vigorously contracting atrium to actually generate the sound against that stiff ventricle. If they're an AFib, for example, an S4 is just physically impossible.
And how do we actually catch this one? It's best auscultated with the bell, again, held lightly at the apex, but this time specifically during patient expiration. And honestly, this brilliantly illustrates the overriding theme of this whole explainer. You aren't just passively listening. You are actively timing your listening with the patient's respiratory cycle and physical position to isolate these specific frequencies.
Which brings us to our final part, Section 5, the auscultation cheat sheet. We have covered a massive amount of cardiovascular physiology today, so let's consolidate all of it into a high-yield visual tool you can actually use on your clinical rotations. Seriously, burn this definitive summary table into your memory. It perfectly divides the acoustic world for us. Over on the one side, we have our high-frequency added sounds, the ejection clicks, the opening snap, the pericardial knock. These are usually characterized by soft, musical, or sort of blowing descriptions. Because the pressure difference generating them is wide, you got to use the diaphragm, pressed firmly. On the other side, we have our low-frequency added sounds, the S3, the S4, and our friend the tumor plop. Notice the vivid acoustic metaphors here. These are rough, rumbling, or thud-like sounds. They result from low pressure differences, and they literally demand the bell applied very lightly if you want to hear them at all.
So as we wrap up this explainer, I really want to leave you with one final provocative challenge. When you walk into your next patient's room and reach for your stethoscope, I want you to ask yourself, what crucial diagnosis will you miss on this rotation if you forget to tune your instrument? Think about it. If you don't flip to the bell, if you don't roll them to their left, if you literally just listen for the lub dub, you're only reading the cover of the book. Master the acoustic instrument, actively apply these techniques, and I promise you will unlock an entirely new level of clinical diagnosis. Thanks so much for hanging out with me today to explore the fascinating acoustics of the heart.